Hey, welcome to Golden Chat, where we provide straight talk. Each week, we deliver insights and tips on senior living. I'm your host, Stella, with your co host, Pedro. Good afternoon.
Hey, good afternoon. Welcome,
So,
Daniel.
yeah, and I was about to get there. So, today we have a special guest, Daniel Santelli, which is Dr. Daniel Santelli. And he's going to talk to us about pain management and the elderly. So this is what we actually want to talk today about, and we're going to try to put that in a context of senior living, so people over 55 and plus, assisted living as well, independent living. See how it all connects. So we're going to start with introducing you and talking about a little bit what you do. So tell us who you are and what you do.
Okay, thank you, Stella and Pedro, for having me. My name is Dr. Saint Eli. I'm a board certified pain management physician as well as board certified in physical medicine and rehabilitation medicine. So, what I do is, as the name entails, I take care of people who've been in pain, especially chronic pain, especially one of the diagnoses that I take care of the most is low back pain.
Got you. So, Daniel, let me ask you. I want to just get right into this. We've had some callers in the past, and we've just been waiting to find an expert such as yourself, so that we could have some of the questions addressed. But in assisted living facilities, long-term care facilities, seniors are starting to want those who are at least on opiates, right? Are wanting to remove themselves from opiates because it's just they've just had some bad effects. And what what the calls have been is they want to begin to use medicinal marijuana, right? So my question to you is, have you seen a rise in uh appointments, treatments with the population 65 and over in your practice?
Yeah, definitely. So since marijuana became legal in 2016, there's indeed been a rise in patients being interested in marijuana and using that as an option. So marijuana is quite complex since it's also an evolving type of industry as well. And the state of Florida is at this point a medicinal state. So on a federal level, all the states are not approved or haven't made marijuana legal, but the state of Florida has. But we're currently only at the medicinal level, and I suspect in the years to come, it's going to become recreational, where people could have brownies and edibles and so forth.
Got you. How do you see long-term care facilities managing, those recommendations? Because I've learned today also that in the state of Florida, it's not a prescription, it's a recommendation that has
Correct.
to be then filled at a dispensary, not a pharmacy. Is that correct?
That's correct.
Okay. So what do you think that it's going to look like in the future with long-term care facilities and marijuana medicinally?
Well, I think first of all, a patient will need to have a qualifying condition. So there's the state of Florida has about 9 to 12 qualifying conditions such as multiple sclerosis, chronic pain, cancer pain, and others, glaucoma and so forth. So that's the first criteria to be qualified. And I think uh, patients 65 and older, I think a lot of them will meet those criteria, but it has to be clearly documented. And the facility have to also identify those individuals as well. And other things have to be met as well, such as other options have to be tried and failed as well. So it's not a situation where we marijuana is just being done just for the sake of doing marijuana. So there's some very strict and criteria that were already set by the Department of Health in the state of Florida. So that's
Got you.
So what kind of treatment for all those pain that you mentioned before, neck pain, bad knees? Because we know when you get to a certain age, and we mentioned that before, over 50, over 40, you start seeing symptoms on your body that actually change your ability, your physical abilities. So we want to know what kind of treatment that you recommend first before even getting to like more medicinal treatments.
Okay, so my answer is that so when somebody has pain, this I usually tell my patient that there's typically four main options. So when you any type of medicine, we always go from what's the easiest to the most conservative to the most aggressive. So your
Okay.
most conservative will be stretching, walking, physical therapy, chiropractic. So basically a form of physical activity. So that's your least invasive. Then you would go to some type of medication. So whether it's your over-the-counter Tylenol or ibuprofen and so forth. And then you could delve into um, like creams as well. And then you can delve into more prescription type of medication, such as nerve medication, muscle relaxant, and then finally there's your opioids as well. So usually you kind of go very progressively as into the medication that are quote unquote less risky to those that are quote unquote more risky. But that being said, there's no medication without side effects. Um,
Right.
so that's pretty much that. Then after that, there's interventions as well. So such as steroid injections, which you've probably heard before. Steroid injections are a form. So steroid is an anti-inflammatory, a very potent one that is. And the goal is to bring the medication where a patient most need it. So it could be a joint such as in the spine, it could be a joint such as elbow, knees, and so forth. So the goal is we know that typically pain is associated with inflammation. So the goal of the injection is to decrease the inflammation, and we're hoping with less inflammation, we'll have less pain. Some people do very well with it, some people do as uh, in between, and some people may not do as well. But by and large, most people do very well with it.
So, Dr. Daniel, what would be the frequency of a steroid injection?
A very good question. So some of my colleagues, sometimes we do series of three. It depends on what it is. So sometimes we could do an injection like back to back, maybe a week apart. I like to really do, and the goal of doing that is to kind of concentrate the medication to get optimal relief. Usually, my way of doing it, I kind of do the injection and see how they do, and depending on the outcome, we could either stop there or we could do further down the line. So, in terms of frequency, it could be a series every 3 months or so.
Gotcha. So you're saying that the pain could possibly dissipate for 3 months
Correct.
on an
And some
injection?
people,
Gotcha.
that's correct. So some people may have partial relief, some people may have full relief. And then the question is, how long will it last? So there's some patients they had relief for a year, some people had for months, some people had for weeks. So it really depends on the individual.
Got you. In your professional opinion, if
Mhm.
individual, let's say in their 50s, right, are on an injection every 3 months, in their 60s, are they still on injections, or have they graduated to maybe a something? I mean, I'm not sure. So how's the progression as you age? Because as you age, I'm assuming that this chronic pain that they're in is probably getting progressively worse in some kind, unless there's going to be surgery involved. So how do you see that in your professional opinion, in the aspects as individuals start getting into their senior years?
Okay. So there's different criteria, and I'll try to generalize. Injection for some people is to kind of prevent like flare-ups or to help them when they have flare-ups.
Okay.
Others had in surgeries, and surgery didn't quite work as well as they thought, and it's to kind of keep them somewhat comfortable. So we can have injection before surgery or after surgery, depending on what the patient has. Some patient also has had multiple series of injections, and after a while, it might not be as effective, if not effective at all. So in that situation, other options have to be sought out. And then there's also different type of injections as well. So I mentioned joint injection, but we do injections in muscle. We do injection like as nerve blocks. We also burn
Gotcha.
nerves as well. It's called radio frequency ablation. So there's multiple options. There's also a procedure that we do called spinal cord stimulator. That's a little bit more involving, but it's a device that's implanted in the spinal cord, and the goal is to block the pain signal. So there's, besides steroid injection, there's other options that we also have as well.
And does that go hand in hand with opioids, or is that in lieu of?
So some people, despite our best efforts, we've tried everything, then uh, they have injection and opioids, or sometimes they end up being on opioids because everything else has failed. So
Gotcha.
that has happened as well.
So,
I have one
I'm
more
sorry, go ahead.
question,
Go
and then
ahead.
Stella, I'm gonna let you. And I apologize for other. So
You're
it's
fine.
it's fair to say sometimes you hear people talk about chronic pain, and there are individuals will be like, well, ear pain is not that bad. You don't need those drugs. Why are you doing this to yourself? You know that you can get addicted to opioids and stuff. Could you, maybe if you could take the time to explain chronic pain a little bit so individuals understand and they're not so biased, because it's not like a headache, or a headache pain. Some individuals think that you should be able to work through this pain, where sometimes I hear chronic pain can keep people in bed on, there's a lot of things that it affects. Could you maybe touch on a couple?
Sure. So the first thing I would say is that we all have different bodies. So, sometimes I see women come with their husband and they say, hey, my husband, his pain level, like sometimes they would kind of joke that the husband can tolerate pain when they were able to endure labor pain. So we have different bodies, and people have different thresholds as well. So we could have the same pain, and I might be jumping off the roof, and you might be very calm and collected even though you're in pain. There's also the aspect that pain is cultural. So some cultures might be more open to be more expressive of the pain. In the other cultures, they may be suffering a whole lot, but they might be more subdued. And there's also people with chronic pain also have had, some of them have multiple comorbidities such as depression, anxiety. So sometimes you have that pain cycle that becomes a vicious cycle. So sometimes people work up, they work themselves up as well. So it's a very, pain is a very complex issue. It's multifactorial as well. There's also genes that were passed down as well from generations too. So some people are very sensitive to pain as well. So so to your point, there's not one size fits all. In terms of the opioid, we also know that people could become addicted, and some of it is to no fault of their own. Is that opioid has you become tolerant. So let's say you start with hydrocodone 5 milligrams, maybe twice a day. Eventually, that same 5 milligrams twice a day will become 5 milligrams 3 times a day. It's because your body doesn't recognize it as what it used to be. So eventually you need to do a dose escalation, and that's when things become a little dicey. So that's why personally I've done opioid rotation, so changing the chemical so the receptor won't be as used to that same chemical. But by nature of our bodies, anybody becomes tolerant, even somebody who I don't think nobody comes in the door saying, hey, I want to be addicted to those medications. So there's a responsibility on both the patient as well as the physician as well, not to just do only opioid, but just do a balanced treatment. So a little bit of anti-inflammatory, some injections, some therapy as well. So I believe with a balanced treatment, we could curb potential risk for addictions. And some people are more prone to be addicted due to their biological makeup as well.
Stella?
Yeah, thank you very much for that. That was very informative.
Yes, thank you.
I'm curious to know how were people able to get treated during COVID-19, and how was your practice any different from before? And what did you resort to? How were they able to access to those treatments?
A very good question. So COVID obviously affected most of us in one way or another, either very good or very bad or in between. In terms of my practice, so what we had to do, we did a lot of telemedicine. So obviously there was a ban from the governors in terms of injections. Injection were considered non-essential, so all the non-essential medical service were banned for about 5 to 6 weeks. So I couldn't offer any type of injections to patients. However, those on opioids or on other medications, I was able to do their monthly their monthly refills as well and still evaluate them as well. So it was a little tricky because I have to protect patients, but I also have to protect myself as well. So that's what we've done as well. And I guess in all bad situations, sometimes there's always some good that will come out. So I think telemedicine has taken a bigger push as well, and uh, physicians and people in the industry will become creative. So that's how we've done it. So now I'm still incorporating telemedicine in my practice. Um, there's some things obviously that I can do via telemedicine, but I think it's a good tool, and telemedicine is here to stay. So in my industry for pain management, that was not allowed prior to COVID. So Medicare and the Centers for Medicare and Medicaid basically allow that, and the other payers kind of follow suit. So I'm sure they're still kind of working through some things as well, but it's been definitely a help to a lot of people. So I think it would have been, if it wasn't for telehealth, a lot of people would have ended up in the emergency room, and that would have created a even greater problem than we already had on our hands.
Dr. Daniel, that's,
Mhm.
you made me think of something. So with telemedicine, right? Would this, w- is it fair to say then in the future, it's a possibility that you might have patients that are from other states that may want to see you that could be seen that way? Or is that something that may not happen? And I'm just had a thought just because you said that.
Oh, very good question. So that's a question that has been thought out. I'm not an expert on the topic, but my understanding is, so for physicians, we are licensed by state. So
Okay.
I'm, as a Florida licensed physician, I can only practice in Florida.
Got you.
When it comes to telemedicine, I'm not sure what the guidance time, but my understanding is that I would have to be licensed where the patient is. Maybe that's changing or that has already changed, but to my best knowledge, I can only practice within the regional confinement where I'm licensed. I think
Okay.
things may change with time, with the globalization of medicine.
Got you. Thank you.
That's a fair question. So it was very nice to have you today, and thank you for all those information, not only for us, but for all our listeners as well, because now it's understanding your options, understanding what you can do, what the process before getting to the medical. Now, how do people find you? How do they find you? How do they get access to you?
Okay. So to have access to me, you can call my office. My office name is Pin Asia. 531 8069. So I will repeat that again. 407-531-8069. Or you can go on our website, which is pinalgia.com. I think I should probably spell that out. Pin like info, like pin, and the last part is
Hmm.
elgia.com. And that's where you
Okay.
can find us.
Do they need a referral to come and see you, or they come and see you?
Yeah, so patients could call us and we will have to verify the insurance and basically seek what type of services they are seeking. And depending on if we carry the insurance, we'll be able to see them or not, or come up to some type of understanding. But I think the first thing to do is to call and we will sort it out from there.
Okay. Sounds awesome. Sounds awesome.
And thank you
Well,
for
that
having
was
me.
great. Yeah, thank you for being there and giving us all this great information. And if you have questions, please give us a call at 321 236-9633, or you can email us at hello@easierlivingforyou.com. You could find all our previous podcasts, including this great one today with Dr. Daniel, at www.easierlivingforyou.com. I look forward, Stella and I look forward, and Lana look forward to seeing you next week at 12:45 p.m. Dr. Daniel, it's a pleasure.
Pleasure. Thank you.
Thank you very much.